All right, we're going to go ahead and start the presentation in the interest of time. For those of you who don't know me, I'm Jan McAlister, past president of CELA, and just wanted to welcome everybody to CELA Speaks tonight. We have the largest pre-registration of any of our CELA Speaks. We're up to about 75 individuals, so they will continue to keep coming into the room. For those of you who may not be aware, the CELA Speaks has been approved for 1 hour of continuing education. When you received your email for a reminder of the program tonight, there is a link to a survey. In order to obtain your CME credits, you will need to fill out that survey, and in turn, you will receive your certificate for a 1 hour of continuing education. So I'm going to go ahead and introduce our speaker. We have the pleasure of having Dr. Michael Blaha, MD, MPH, professor of cardiology and epidemiology, and is the director of clinical research and the director of the cardiometabolic clinic for the Johns Hopkins Cicerone Center for the Prevention of Cardiovascular Disease. Dr. Blaha has published over 650 scientific articles with a focus on appropriate use of tests and new therapies in the prevention of atherosclerotic cardiovascular disease. In 2018, Dr. Blaha received the Dr. Fred Brancati Award at Johns Hopkins for excellence in mentoring. He has mentored over 30 trainees, many of which have gone to hold prominent academic appointments. In 2021, he was named the Clarivate highly cited researcher list, representing the top 1% of world's researchers. In 2022, he received the Arthur S. Agustin Cardiovascular Disease Prevention Award. Clinically, he practices as a preventative cardiologist, specializing in cardiometabolic disease and the interpretation of cardiac CT. His clinic specializes in patients with cardiometabolic disease and advanced subclinical atherosclerosis, and the focus use of an array of lifestyle and pharmacotherapies to mitigate that risk. We are in a time crunch this evening, so we are hoping to be finished by 7:45. So in the interest of time, for those individuals who have questions, if you can write the questions in the chat session, I will get those questions to Dr. Blaha at the end of the program. And without further ado, Dr. Blaha, thank you so much for joining us tonight.
Yeah, it's my pleasure, and thank you for the introduction. I think everyone will appreciate, hopefully, being done at a good time tonight since you're joining on an evening. So thank you for enjoying this evening. So the introduction was perfect because, right, I practice as a preventive cardiologist, like many of you do, with an interest in atherosclerosis, particularly advanced atherosclerosis, and particularly thinking about new modalities for lowering risk. And that's what brings us to talk about inflammation today. I think everyone is very familiar and probably very aggressive when it comes to treating lipids in their practice. I think we're all treating to aggressive blood pressure goals. But the question is, are we dealing with inflammation in our patients, both for the lifestyle or new pharmacotherapy? So that'll be the focus today. Lowering ASCVD events by treating residual inflammatory risk. And really, we'll focus on low-dose colchicine because that's where the data is right now. So let me go over the objectives. Hopefully everyone's clear what I'm trying to accomplish, and hopefully I can accomplish it in time. And please ask questions for anything I don't cover. So first of all, we'll define residual risk. Describe how inflammation is integral to the pathophysiology of atherosclerosis, and it should be considered part of our residual risk spectrum. Then we'll review the data on low-dose colchicine for the reduction of ASCVD events. And then I'll describe the future of cardiovascular risk reduction, with maybe inflammation as one of many potential targets we'll be choosing in a precise way for our patients, kind of redefining the concept of residual risk and focusing on one subtype of that risk, residual inflammatory risk. Okay, so let's start off by talking about residual cardiovascular risk. What is it that we're talking about? I think most of us in the lipid space are used to this term, but it's worth defining. I mean, if you look at residual risk across many different fields of inquiry, it's really defined as the risk that remains after some basic types of risk mitigation have been applied. It's the leftover risk after basic things have been done to mitigate the most of the risk. So this is what's commonly shown kind of to engineering groups. Kind of there's an inherent risk, there's some controls, but there's always residual risk in any system that exists. And we try to define that, categorize it, and treat it. So the typical example that's given in like corporate or engineering textbooks is that residual risk is, for example, the risk left over of driving a car despite having a seatbelt or despite having your headlights on. There's still risk inherent in driving that vehicle. And likewise, of course, there's still risk inherent in atherosclerotic cardiovascular disease, even after we've done the basics, the standard of care. So really in atherosclerotic cardiovascular disease, we interpret residual risk as the risk that exists, that we know still exists after you've done basic standard of care, which basically in this ASCVD space means an aspirin and a statin, right? So looking at this in more detail, we know this, that residual risk remains after marked LDL reduction from the major statin trials. This is from 4S on the left to cards on the right. Many of you guys are, of course, familiar with this data. These data, blue is the control group, red is the statin group. Despite the remarkable benefits we see with statins in patients at varying risk of ASCVD, a lot of risk still remains despite statin treatment. If you look at those red bars, right, there's still a substantial amount of events that occur in the statin trials. Something has to explain that residual risk after just statins. So that's what we're talking about today. Most of these patients, of course, are on an aspirin in these trials. They're on randomized to statin. So despite the statin, we have residual risk, and we need to look for novel mechanisms of risk to really try to get at this the best we can. And what we're going to talk about today, of course, is inflammation. A new pathway for risk lowering, because we know for years now from the work from the folks you see, the luminaries on this slide, including Dr. Libby, that atherosclerosis, as it said in the upper left corner, is an inflammatory disease, right? These are three seminal New England Journal articles dating back from 1999 to 2013, talking about how inflammation, atherosclerosis, and coronary disease are all part of the same process with kind of iterative, deeper understanding of how this works. But basically, of course, injury to the vessel wall, entrance of lipids into the vascular the wall space, and a process starts called inflammation that can be described, that's programmed, that's familiar across organ systems, and potentially that can be treated. So once again, inflammation, atherosclerosis is an inflammatory disease. In fact, we've learned a lot about inflammation and atherosclerosis from imaging. I'm an imager, and these are some particular imaging tools that taught us about inflammation. Here in the upper left corner, you see kind of a cascade of events that happens in the wall of the blood vessel, ranging from penetration of leukocytes into the wall, attraction to the lipid core of the plaque, where you might have cholesterol crystals and other vascular injury, starting the assembly of an inflammasome in this inflammatory cascade. Well, anything from gallium dotatate imaging, which helps image macrophages that can be seen at the site of atherosclerotic plaques, to FDG PET that marks active metabolism, or in this case, inflammation. We know that sites that are highly active with FDG PET are the most likely to rupture, or we use FDG PET tracers after acute plaque ruptures. We see activity at the site of the plaque rupture. And tools like sodium fluoride imaging marks active calcification. We know that calcification is part of the development of atherosclerosis that occurs in something like a healing process after a plaque is disrupted. We see that active calcification following inflammation, for example, after an acute event. So once again, we've learned a lot that inflammation is part and parcel with atherosclerosis, at least in its moderate to advanced stages. And markers of inflammation can be markedly predictive of events. This dates back to Paul Ridker and his many studies, the New England Journal of Medicine, dating from 1997 to 2002, as I'm showing here. seminal studies showing that C-reactive protein, which is a downstream readout of inflammation in the body that we'll talk about, is highly predictive of events independent of LDL cholesterol. In fact, another marker like IL-6, for example, is also predictive of events independent of cholesterol. You see on the right here, this idea that actually, if you separate folks by quintiles of inflammation, C-reactive protein in this case, or quintiles of LDL cholesterol, you see similar risk stratification of patients using a test like C-reactive protein as you do with LDL cholesterol. And we'll see later that they're actually additive. So after years of follow-up, just a baseline measure of inflammation in the body can be highly predictive of events. And we also know, once again from Dr. Ridker and others, that patients who have inflammatory disorders have a heightened risk of atherosclerosis. For example, here, looking at patients with rheumatoid arthritis, and you look at their vascular beds, they have much more atherosclerosis than would be predicted on their traditional risk factors alone. And of course, this is well described for psoriasis, inflammatory bowel disease, and many other inflammatory conditions now. So starting to understand that, once again, inflammation is a familiar process throughout the body, multiple steps we could potentially intervene on. In this case, that all read out, in this case, with an end-stage marker, C-reactive protein that's made from the liver that can be used as a general measure of inflammation, particularly one that's more sensitive to vascular inflammation. So we'll talk throughout this talk about how the top here, the NLRP3 inflammasome, is assembled, starts a cascade with markers like IL-1 beta and IL-6, which feed forward to the liver, and ultimately markers like C-reactive protein are dumped into the bloodstream and can be measured as a good readout for inflammation. So as I mentioned, there's lots of interesting activity going on in terms of treating inflammation to reduce cardiovascular risk. And we're going to talk about this NLRP3 inflammasome cascade quite a bit during this talk. Once again, NLRP3 inflammasome assembles IL-1 beta, IL-6, C-reactive protein. So we'll talk about this NLRP3 inflammasome, which is like an organelle that assembles in response to tissue injury or mechanical injury or other foreign bodies. It starts this kind of programmed innate immune and inflammatory response. And that's where colchicine works that we'll talk about today. Colchicine helps to inhibit microtubulin and the mobility of leukocytes that help to form this inflammasome and help to disrupt the formation of the inflammasome. So we'll talk about that. We'll talk about anti-IL-1 beta therapies like canakinumab that was tested in the CANTOS trial. We'll talk about future therapies that might target IL-6 like ziltivekimab that are under investigation now also, which lower CRP and potentially lower cardiovascular events. And lots of interesting new potential implications of treating inflammation. Some of these therapies on the left are being tested for heart failure, acute MI, chronic ASCVD, of course. There's other things like peripheral arterial disease. So lots of interest in inflammation as a potential target of therapy for multiple disease states. But we're going to focus on ASCVD, of course, today. So I want to walk back to the CANTOS trial, which many of you remember. This was published in 2017, of course, by Dr. Paul Ridker. And this was a large study, over 10,000 patients with a myocardial infarction treated with the antibody, anti-IL-1 beta antibody canakinumab. The idea here was by targeting IL-1 signaling, you could have diffuse effects on the endothelium, on smooth muscle, on leukocytes themselves that might all not have salutary effects on atherosclerosis. And of course, what CANTOS showed was that canakinumab reduced ASCVD events in this high-risk population with recent MI by 15%, which raised all sorts of interesting questions about mechanism, as well as signals in the study that maybe there even could be a reduced risk of cancer. So let's look at CANTOS in more detail. So this was a study that looked at canakinumab at a couple of different doses. You can see that when patients were treated with canakinumab, as consistent with the pathway I showed you, CRP went down in a dose-dependent fashion, while LDL cholesterol was not affected. So once again, that proof of principle that we're talking about in an anti-inflammatory therapy with no specific LDL or lipid effects. And here's what the key results for canakinumab on the key secondary endpoint, which is a cumulative incidence of these secondary MACE endpoints. There was a 17% reduction with canakinumab. And intriguing data that Dr. Ridker published later, it seemed to be the patients who had the most CRP reduction, the patients who got their CRPs into the quote unquote normal less than 2 range that had the greatest benefit. So once again, there seemed to be a reduction in CRP and overall benefit, and the patients who got the most benefit appeared to be the ones that have the most normalization or lowering of their C-reactive protein. Now, of course, this therapy, canakinumab, never saw the marketplace for an ASCVD therapy. And I think the reason why it's important is that it's a proof of principle that treating inflammation might be able to reduce cardiovascular events similar to what our lipid-lowering therapies might do. But that was only the initial taste of where we might go with inflammation, because once again, canakinumab is not something we can give patients. But low-dose colchicine is something that's available that we'll talk about now. So, of course, colchicine has been known for a very long time. It's an ancient drug. It's been used since ancient times for its anti-inflammatory properties. First described in ancient Egypt in 1550 BC for treating pain and swelling. So the observation was made very early that this derivative of the autumn crocus plant had anti-inflammatory properties. And there's quite an interesting history of colchicine, as you all know, for, of course, treating gout, treating pericarditis, and lots of interesting science about understanding inflammation and so forth that's come from the colchicine story. But only recently, of course, have we learned about the effects of colchicine, particularly low-dose colchicine, on ASCVD. So colchicine exerts multiple anti-inflammatory effects that potentially have multiple benefits, like we talked about across different disease processes. So as we talked about in atherosclerosis, we have damage to the vessel wall. We have lipids that enter into the vessel wall. We have cholesterol that starts to crystallize and start this innate immune response. So in the bottom left corner, oxidized LDL, cholesterol crystals, and shear stress can start this assembly of this NLRP3 inflammasome and this immune response that's familiar throughout the body, like when you have, for example, gouty crystals in your joint space. So the NLRP3 inflammasome assembles, activates macrophages and so forth, and starts this process. And of course, colchicine, by affecting microtubule assembly, can decrease the motility of leukocytes and decrease the assembly of this NLRP3 inflammasome, have downstream effects on those other markers I mentioned, including CRP, and interfere with neutrophil function, and potentially also interfere with the neutrophil platelet interactions too, and also potentially have anti-platelet effects. So that's why we think colchicine has benefit in pericarditis, might have benefit in atherosclerosis, as we'll talk about. Potentially data also that colchicine might have salutary effects on atrial fibrillation, atrial remodeling, and heart failure as well. So this story really started with the LIDOCA-1 trial. This was a study that was published in JACC in 2013, 532 patients with stable coronary disease. In an open label design, given 0.5 milligrams of colchicine PO daily and followed for events include acute coronary syndrome, stroke, and CV, and CV death. And what you can see here, probably an outsized effect given the open label design, but a very intriguing signal of nearly a 60 to 70% reduction in events in these patients with stable CAD treated with colchicine. This was the rationale to move forward with more studies with low-dose colchicine in CAD. So this was the LIDOCA-1 study, and this then laid the groundwork for the COLCOT study. The COLCOT study was a randomized, placebo-controlled, double-blind trial of nearly 5,000 patients who had a recent myocardial infarction within the last 30 days before randomization. These patients were treated once again with low-dose 0.5 milligram colchicine or placebo, in addition to the background standard of therapy, which of course included in nearly all patients a high-intensity statin. And the outcome was cardiovascular death, MI, stroke, urgent hospitalization for angina, leading to revasc, kind of a 4-point MACE outcome. And this was reduced by 23% in the COLCOT study. You can see the Kaplan-Meier curves on the right here, early separation and sustained separation of the curves out to about 3 years. And serious adverse events were low in both groups. Of course, there's always been concern of colchicine at high doses for adverse events ranging from hepatic to renal to gastrointestinal, but at these low doses in the COLCOT study, there was no major difference in serious adverse events across the groups. Okay. So the next key study that was the other pivotal study, low-dose colchicine, was called LODOCO-2. So LODOCO-2 was published in the New England Journal of Medicine, as you can see, in 2020. It was a randomized placebo-controlled double-blind trial, nearly 5,500 patients with stable CAD, chronic CAD, treated with 0.5 milligrams of colchicine or placebo, in addition to standard care, which again included a statin therapy. That's important. Most all these patients are on statins, so all this data should be interpreted as colchicine added on to basic therapy, which included almost always a statin. The mean age of the patients was 66 years old. And you can see the primary endpoint of cardiovascular death, MI, stroke, or ischemia-driven coronary revascularization was reduced by 31% in the LODOCO-2 study. Once again, serious adverse events were low in the groups, with the primary adverse event being gastrointestinal intolerance, which many of us are familiar with from using this drug at higher doses from gout or for other reasons. Now, there's some caveats about the study. There was a run-in period where a certain fraction, about 10% of the patients, couldn't tolerate the therapy. So this is really best reflected as patients who could tolerate an initial 4-week course of colchicine and what happens afterwards. There was a signal in this study for a potential increase in non-cardiovascular death that was later kind of thought to be from a variety of causes and not really to be etiologic necessarily. So some caveats in the interpretation of this study. But once again, a powerful 31% reduction in events. That's more than what we see from most add-on therapies to statins. So here's a good infographic that I'll leave in this slide deck. Just to understand LODOCO-2 in more detail. Again, the question was in chronic CAD, does colchicine improve outcomes? You can see the inclusion criteria and the key exclusion criteria, which did exclude people with severe kidney disease or with severe symptomatic heart failure. And you can see the primary outcome, the secondary outcome, and then below that, the fact that colchicine was associated with a non-significant trend towards increased non-CVD deaths, although when examined closely, there didn't seem to be a particular unifying theme for why there was an increase in non-CVD deaths. The conclusion of the LODOCO-2 trial was that in chronic CAD, colchicine decreased composite outcome of CVD death, MI, stroke, or ischemia-driven coronary revascularization. And really, it was the LODOCO-2 study, as well as Colcott, which formed the basis for the FDA's evaluation of this drug. So looking back at LODOCO-2, the question comes up, well, who benefited from LODOCO-2 in the study? And really, when you look at the forest plot, it was a really consistent effect across nearly all the groups. So if you look at by sex, by age, by individual risk factors, as you see here, by statin dose, by presence or absence of ezetimibe, there was a consistent lowering of cardiovascular events with low-dose colchicine. Now, again, this is the low-dose form of colchicine. What we might be familiar with is the 0.6 milligram tablet that we might use twice a day, for example, in acute gout. This is a formulation of 0.5 milligrams of colchicine, the so-called low-dose colchicine that was used in all of these cardiovascular studies. So that's the dose that's approved by the FDA, which we'll talk about later. Now, one thing I didn't mention that we'll come back and talk about when we talk about low-dose colchicine is that, well, many of these patients were probably inflamed, so to speak, probably would have elevated inflammatory biomarkers. You did not have to have an elevated inflammatory biomarker to get into the LODOCO-2 study. So this was all comers, in this case, with stable CAD. So really, it's a pretty profound effect, despite the fact that these patients were not pre-selected to have high inflammatory biomarkers. And importantly, the efficacy of low-dose colchicine was consistent based on the timing of the event. So one might say, well, maybe based on the Colcott study, all the benefit is in the near term after your acute coronary syndrome. And maybe if it's used in the chronic phase of the disease, there's not a benefit. But you can see here, although underpowered for some of these groups, in patients with recent ACS, so-called remote ACS or very remote ACS, up to 7 years prior was your ACS event, there was a consistent about 30% reduction in cardiovascular events. And while that group that with no prior ACS, there was a small amount of patients in LDOCO2 that either high calcium score or didn't have a prior ACS. There seemed to be a 20% reduction in that group too. That group is relatively underpowered, but still a consistent benefit, regardless of whether you had, once again, a recent event, a semi-recent event, or a remote acute coronary syndrome. And also the long-term efficacy of low-dose colchicine was confirmed in subsequent studies too. So this is a landmark study that said, well, are all the benefits in the first year of therapy and then sort of you hit a maintenance phase where there's no longer benefit, or does the benefit continue over the course of the study? So you can see here, there's a landmark study from year 1, year 2, year 3, or thereafter. And in year 1, year 2, year 3, even in year 4, there was a statistically significant reduction in the primary and secondary endpoints in this study, leading to the conclusion that there's a consistent effect of colchicine over time in these stable patients with chronic therapy in terms of reduction events. Okay, so I mentioned that CRP wasn't an entry criteria for the LDOCO2 study. So the question is, well, to what degree does colchicine actually treating inflammation? Is it actually lowering C-reactive protein? So there was a sub-study of LDOCO2 that actually looked at some key inflammatory biomarkers. Here, a key protein component of the NLRP3 inflammasome, and in the middle and on the right, C-reactive protein and IL-6, which I showed you are on that same pathway. Suffice to say, in this relatively small study, there was a reduction in key proteins from NLRP3 inflammasome, C-reactive protein, and IL-6. And as you can see here, the conclusion is, again, that the benefit is likely to be due to this reduction of the NLRP3 inflammasome itself and its downstream mediators. Okay, so what about serious adverse events in LDOCO2? I mentioned that there was a run-in, but once patients tolerated the run-in, there was very few serious adverse events in the LDOCO2 study. You can see things that might be serious adverse events of interest in an anti-inflammatory therapy, new cancer diagnoses, hospitalizations for infection, hospitalizations for pneumonia in particular, or a gastrointestinal reason, all were similar with colchicine versus placebo. Significant neutropenia, significant myotoxicity relevant in patients who were treated with high-intensity statin. There's a thought that maybe colchicine and high-intensity statin would lead to more myotoxicity. There was no more major myotoxicity or neutropenia observed in the study. But intriguingly, of course, there was a decreased incidence of gout in the colchicine arm. And in a secondary analysis that was very intriguing, over the course of the study, there was actually a reduction in the need for joint replacement and other joint-related outcomes, consistent probably with the generalized anti-inflammatory effect of colchicine. So probably some additional benefits in those patients with gout or osteoarthritis. This was just another study that looked in detail at low-dose colchicine on renal, liver, and muscle. I won't go through this in detail, but just to look at the conclusion and led to some reassurance for those of you that might be thinking about, well, what about my patients in terms of the renal risk, liver risk, muscle risk? It said in chronic coronary disease patients, 2 to 4 years of exposure to colchicine 0.5 daily was only associated with small elevations in ALT and CK, but no changes in overall renal function. And as I showed you, no more major myotoxicity. So one of the questions that always comes up here is, well, why low-dose colchicine at the 0.5 milligram dose rather than standard colchicine at 0.6? It's a good question. It's one that we need more answers on. But one of the rationales is that colchicine at its lowest doses preserved the general safety profile of colchicine. So what this is showing here is with patients that have either normal renal function or in this case, some renal impairment, what do the levels in the body look like with 0.5 milligrams, 0.6 milligrams? And you can see that as renal function starts to impair, with the 0.6 dose, you start to get levels that can get up into ranges that we think that might potentially be less safe. Well, the 0.5 milligram dose, this might be relevant for patients that are older in age or have renal impairment. We think we see levels of colchicine that generally are consistent in what we thought to be the safe range. So the idea is that low-dose colchicine might reduce the potential risk of side effects while preserving the anti-inflammatory aspects of the drug. Another thing to think about when you think about colchicine is drug-drug interactions. Short-term discontinuation of low-dose colchicine is recommended if there's a moderate to strong inhibitor of cytochrome 3A4 or P-glycoprotein are anticipated. And this really comes up with the drugs below, for example, if there needs to be one of these antibiotics or antifungals that are familiar, cytochrome 3A4 inhibitors. This would be a situation where colchicine should be stopped or potentially not used if the patient has to be chronically on one of these medications. And of course, even though low-dose colchicine is safe in these studies, it's still advised to avoid patients with seriously impaired renal or hepatic function with colchicine. Okay, so let me summarize this clinical data and take us up to the level of FDA approval and then your clinical practice. So this is a meta-analysis of all the studies that looked at low-dose colchicine for cardiovascular risk reduction on myocardial infarction, stroke, and CVD death in the top, including revascularization on the bottom. And you can see here something like a 33 to 25% reduction across these endpoints when you look at LODOCO-2, COPS, COLCOT, and LODOCO studies. And overall, it looks to be pretty consistent with relatively low amount of heterogeneity across these studies. But mind you, there's no reduction on all-cause mortality. In fact, in these meta-analyses, the overall point estimate for all-cause mortality was 1.0, straddling the confidence interval straddles completely around 1. So while there's an effect on cardiovascular events, it doesn't appear to be effect on mortality. And actually, as you know, this is consistent with what we see for many cardiovascular drugs, including the lipid-lowering drugs like ezetimibe, bempedoic acid, or PCSK9 inhibitors, where we see a reduction in MACE events on top of a statin, but we don't see an effect on all-cause mortality. So as you probably know, in 2023, a branded version of the low-dose colchicine was brought to the market called LODOCO. And I just wanted to go over the package label for LODOCO so we can understand exactly how the FDA interpreted this data and they imagine us using it in clinical practice. So there's a very, very broad label, actually very consistent with that for statin use for LODOCO. So I'll read that. It says to reduce the risk of myocardial infarction, stroke, coronary revascular, or cardiovascular death in adults with established ASCVD or consistent with a subgroup in LODOCO-2 with multiple risk factors for cardiovascular disease. So this is a very broad label that sounds much like statins, a general cardiovascular risk reduction label. As you can see here at the bottom, there's contraindications for patients on strong cytochrome 3A4 inhibitors or P-glycoprotein inhibitors, and it's generally contraindicated in patients with blood dyscrasias, severe renal failure. It mentions a creatinine clearance less than 15, but be cautious overall, or severe hepatic impairment. And interestingly, the mechanism of action in the FDA label, of course, is listed to be anti-inflammatory. But of course, the label's only mention of C-reactive protein here is in the mechanism of action. These anti-inflammatory effects are consistent with clinical data demonstrating that colchicine reduces C-reactive protein, but there's nothing in the label that says you need to have a high C-reactive protein to treat with colchicine. So that leads to that interesting kind of conundrum that we come up with now is who best to use colchicine in. Now, it's probably patients with inflammation, but there's no mandate that you measure inflammation before you treat. Okay, so what is the future of residual risk reduction based on what I've talked about? So let's go over this case. I think everyone will find this case familiar to their practice. 64-year-old man. He has hypertension, prediabetes. He had an anterior MI 4 years ago with 2 stents. He has gout and osteoarthritis. If you look, his blood pressure is fairly well treated. His LDL is fairly well treated, but he's got a lot of other markers of residual risk, right? His BMI puts him in the class 1 obesity range. His left ventricular ejection fraction is slightly impaired, but still preserved at 50%. His A1C is in the pre-diabetic range. His HDL is a little low. His triglycerides are high. He actually has a high LP(a). He's a stage 3A CKD patient with a little bit of microalbuminuria and a C-reactive protein that's high. So the question is, after blood pressure control and LDL reduction in this current era, how are we going to treat this patient? We have lots of options. Do we attack his triglycerides? In the future, maybe we'll treat his LP(a). We could use kidney preserving drugs, lots of options. So how do we think about patients like this? Of course, I'm going to focus on this gout and osteoarthritis and the C-reactive protein in this patient. Make the case that this patient has residual inflammatory risk. So this is a great paper from European Heart Journal that talked about the categories of residual risk that we're really looking at in this new age of preventative therapy. Residual cholesterol risk, of course, we have data for further LDL reduction. Residual thrombotic risk, we have data for dual antiplatelet therapy or low-dose rivaroxaban, triglyceride therapies, LPA therapies on the horizon, lots of cardiometabolic therapies. But of course, there's this other category of patients with residual inflammatory risk who have potentially C-reactive protein that's elevated or other markers of inflammation who might benefit from anti-inflammatory therapy. And this is this idea that maybe we need to be thinking about our patients and what's the most abnormal, so to speak. What's driving the risk? Let's consider this patient with known cardiovascular disease and an LDL of 150 and a high C-reactive protein. You give a statin, and one of two outcomes can happen. One, you lower LDL to quote unquote goal, it's less than 70, but the C-reactive protein remains high. Or maybe on the left, the patient's LDL doesn't get to goal and the C-reactive protein actually comes down to goal. Are these different? Does one have residual cholesterol risk? Does one have residual inflammatory risk? And should that be informing our next choice of therapy? As you can see, what I'm getting at, maybe on the left, we need adjunctive LDL lowering, and maybe on the right, we need to be thinking about inflammation because the LDL is already fairly well controlled. And intriguing data from Dr. Ridker from Lancet, looking at pooled data from clinical trials, shows this idea that in patients that are treated with statins, that it appears that the residual elevation in C-reactive protein is more predictive of cardiovascular death, for example, on the right, than residual LDL elevation. Maybe hinting at this residual inflammatory risk concept in these patients that are on statins who have high C-reactive protein or at our highest risk of cardiovascular death. And Dr. Ridker breaks this down here and showing that if you look at these trials, there's a fair amount of patients that have residual cholesterol risk, but there's a lot of patients who have residual inflammatory risk, even more that might have residual LDL or CRP elevations rather than LDL elevations after high intensity statin. So I'll just wrap up by saying that guidelines are coming around and including colchicine. This is first of all referenced in 2021 ESC guideline on cardiovascular disease prevention, has a special section on anti-inflammatory therapy now. That's great. And we've seen recently the ESC chronic coronary syndrome guidelines that were just released at the ESC, a class 2A recommendation for low-dose colchicine, level of evidence A. And in our chronic coronary syndrome guidelines here in the USA, a class 2, I should say class 2B recommendation there for colchicine in our guidelines. So class 2A, class 2B recommendations for low-dose colchicine in patients with chronic coronary disease. So let me step back and summarize what I've mentioned here, as I've covered a lot here, and say that there's many mechanisms of residual risk. And the future of prevention will be personalization of therapy to match the purported mechanism. And that residual inflammatory risk is now a well-established concept that can be treated with an FDA-approved therapy, low-dose colchicine. And it's now up to us as clinicians, as well as guideline writers or thought leaders or lipidologists in the audience to decide to more clearly define the routine role of low-dose colchicine or the routine role of CRP testing in general in practice, including, of course, patients in secondary prevention, but also our patients in high-risk primary prevention who might not have other major risk factors to treat. Where does C-reactive protein fit? Where does low-dose colchicine fit? So really, it's an exciting time where we have more therapies than we ever had before, including a new mechanism, treating inflammation. And I'm just starting to kind of get used to routinely measuring C-reactive protein and using colchicine in my practice and having good results. And I'm curious to hear from others kind of what their experience with low-dose colchicine. So I'll close there and maybe spend 5 or 10 minutes answering your all's questions. Thank you very much.
Thank you so much, Dr. Blaha. That was absolutely wonderful. Appreciate all of the information. We do have a couple of questions, one of which you essentially already alluded to. Does colchicine have a role in primary prevention? And it kind of sounds like you said, stay tuned, let's wait and see.
Yeah, I mean, I think the key part about that is high-risk primary prevention. I mean, in our run-of-the-mill prevention patients, let's say who have an LDL elevation, of course, it's going to be a statin. But we're very intrigued by the patients who come to us with advanced subclinical atherosclerosis, for example, very high calcium scores, CT angiography data suggesting obstructive disease, who haven't had an event yet, but maybe their LDL is well controlled. So I think that's an area we've crept into thinking about colchicine in primary prevention too, but that special group of high-risk primary prevention patients.
We also had a couple of questions regarding your case study. One question was, given the elevated triglycerides, would it be more appropriate maybe to measure ApoB and not the calculated LDL?
Yes, I designed this case intentionally, of course, to get everyone thinking, right? Because the point is, in other lectures I've even had people raise their hand and said, "What would you do in this case?" And of course, you get very differing answers. If you go to a nephrology audience, they say, "Well, you gotta use a kidney protective drug here. He's got stage 3 CKD and a UACR that's elevated, right?" Other audiences say, "Well, gosh, you got to treat the triglycerides, or you got to get that ApoB down further." Of course, soon we might be saying we got to get the lipoprotein A down. So I think the point is that we've got to start thinking about patients like this and start thinking about what's driving the risk. Now, of course, I picked a patient that had many different mechanisms of risk. But we got to think about that patient, what's driving the risk, and try to identify those patients who maybe inflammation is actually one of the key drivers. So yeah, of course, there's a lot that could be done for that patient, but I think that what's intriguing is that we probably need to arrive at some consensus so that we don't do it differently.
Yeah, and someone actually brought up treating the insulin resistance, which would also drive down the
Yeah.
inflammation and proteinuria. So, with all of this data, with everything being said, why do you think providers aren't prescribing it more often?
So this is a great question, and I figured this would come up. And I think there's multiple reasons for that. Number one, I mean, this isn't a new entrance. It's a new entrance in the marketplace in terms of this label, but of course, colchicine is something we're familiar with. And while you might think, well, that should lead to more familiarity, I think it actually sometimes leads to more hesitance too, because we're used to using it in different indications. And it's just an unusual concept for many of us that we're going to be treating inflammation. So I think there's just needs to be a new comfort level with understanding the biology here and using low doses of anti-inflammatories to treat inflammation. So there's that concept. Of course, this therapy is not one that's heavily marketed. You're not going to see, except for people like me giving some general information on this, you're not going to see a lot of other talks and so forth on this. So that's another reason I think that the message isn't out as much, which is why I like to talk about it. Of course, this also will be supported, hopefully in the future, by other positive data for other anti-inflammatory therapies. And then, then we're going to look back and say, well, it makes all the more sense then that colchicine works. I think all those reasons, and also what I mentioned just about that case, there's lots of other things that you could be using in that case.
And it seems like the 0.5 milligram dose is a little bit more cost prohibitive than the generic 0.6 milligram colchicine that we're all familiar
Yeah.
with. Is there a rhyme or reason to that other than to make money?
Well, it's interesting. I mean, this was tested long before there was a avenue towards commercialization of this drug. So I think the thinking there originally was to use low doses of colchicine, lower than what were used for gout and whatnot in those original kind of academic-driven trials. And then since the data accumulated with 0.5, of course, that's why I guess that was what was brought to market. That's where the data is. So this is a tricky question, right? We always want to stay evidence-based and say, well, the data is for 0.5, but of course you can't help but ask the follow-up question, well, what would we see with 0.6? So of course, the reality is most of the time, at least in my practice, I try to get access to 0.5 so that I can have, a drug that's actually has an indication for cardiovascular risk reduction. If I can't, I use generic colchicine. The one thing I struggle with the 0.6 a little bit, other than the data is with 0.5, is there can be a lot of confusion too about when you use it with other providers. They say, oh, this patient doesn't have gout, or why are we using it? Well, the 0.5 has sort of its own place, but I get it. And I would wish we had more data comparing 0.5 to 0.6, but I just lean on the fact that the data is with 0.5. And I think it's increasingly available as these guidelines endorse it. It's actually, to my knowledge, it's cheaper than most other drugs that we use, but you're right. It's certainly a lot more expensive than generic colchicine. So it's a legitimate question. I certainly have many patients on generic colchicine and on Wadoco.
Well, thank you very much. One last question. We promised that we were going to get him off at a reasonable time, so this is going to be the last question. The question was, do you follow CRPs? Do you, every time you see a patient in clinic, are you using
Yeah.
CRP as a measurement to clinically follow all the time?
This is a good question. I mean, historically, dating back 5, 10 years, I wasn't really measuring C-reactive protein actually, and that makes sense, right? We weren't really targeting as a therapy. I've measured it more often recently, for the reasons I mentioned, although I'm not afraid to use Lodoco, I should say low-dose colchicine, when I don't have a CRP too, because I think that, as I showed you, the evidence is independent of C-reactive protein. But yes, I am checking it more often. And the reason why is because so many things, of course, can treat inflammation. I like measuring my CRP. I have a cardiometabolic practice. I like measuring C-reactive protein. Some of my patients that I'm engaging in weight loss therapy or treating their diabetes, of course, that has potent anti-inflammatory effects. If we're using colchicine, I like to have that extra reason to consider colchicine, that residual inflammatory risks. We'll measure it there. And it's nice to see it come down too. I think patients like to see that. So I think there's no mandate to follow it. But I think there's a lot of appeal to it too. Dr. Ridker has shown patients with the most C-reactive protein lowering get the most benefit. Not necessarily changing my therapy based on that, but I do like to see it come down with weight loss, exercise, smoking cessation. All these, of course, lead to CRP lowering.
Thank you. Well, as promised, we promised he would get out at a reasonable time. Thank you very much, Dr. Blaha. We appreciate you joining us tonight. Remember, 1 hour CME credit. You should have a link to the survey in your confirmation email from the NLA. Once you fill out the survey, you can get your certificate. Thanks again, everybody. Have a great Tuesday evening. This concludes CLIS Speak for September, and we'll see everybody next time.